Hi, everybody. My name is Anne-Marie Gregarian. I'm a pediatric task force member. This is a discussion on the ILCOR Consensus of Science 2020. And from the Adult ALS Task Force, we are very, very fortunate to have our chairs and our co-chairs.
Hi, thanks, Anne-Marie. Again, my name is Catherine Berg. I'm a pulmonary and critical care physician in Boston, Massachusetts, in the United States, and vice chair of the ALS Task Force.
My name is Jasmeet Soor. I'm an intensivist at Southmead Hospital in Bristol in the UK, and I'm the ALS Task Force Chair.
So to focus on the new Adult ALS 2020 Consensus on Science Statement and the treatment recommendations, I'm looking to one of you, and potentially Dr. Berg can start, on what are the main topics people should be looking for.
So I think we aimed at a fairly comprehensive statement this year, but the things that we've included systematic reviews or scoping reviews on include some more controversial topics like double sequential defibrillation. We also looked at intravenous versus intraosseous access for drug administration during cardiac arrest. I think there's been a lot of interest in increased usage of intraosseous devices during cardiac arrest. Also point of care echo, I think because again, growing interest in using point of care echocardiography for prognostication and other uses during cardiac arrest. Also a systematic review on prophylactic antibiotics after resuscitation and seizure prophylaxis. And then very extensive systematic reviews on various aspects of neuroprognostication. So I would also highlight that.
And Dr. Soor, if you had to summarize what are the key highlights to really look for, because a lot of work's been done, but what, in a nutshell, does a clinician need to look for to expect in their own jurisdiction coming out of ILCOR?
The topics that interest me are those that are going to challenge the guideline writers. So if you remember, ILCOR gets a consensus on the science and makes treatment recommendations, but ultimately national councils write the guidelines. So I'll pick out a few topics. So one of my topics, which we covered in 2018, 2019, and again in 2020, is airway management and should we be using tracheal intubation? And there's been 3 large RCTs that all point towards bag mask ventilation. Supraglottic airways are probably just as good as tracheal intubation in most circumstances, and more importantly, you should only be using tracheal intubation if you have a high success rate. So that's the ILCOR consensus on science. How you put that into guidelines where most patients get multiple interventions for their airway over time is challenging. So I'm interested to see how that comes out in guidelines. The other topic that we looked at, which I think will be controversial, is the IV versus IO debate, in that there's been secondary analyses, both from the ROCK-HELP study that compared amiodarone, lidocaine, and placebo, and looking at the intraosseous, intravenous groups. And the data suggests intravenous may be better, but is underpowered to really say that. And again, for the paramedic study that compared epinephrine with placebo, the data doesn't give a strong signal for one or the other. So the ILCOR consensus on science points towards going for an IV, and only when an IV isn't feasible, going for an intraosseous. But we know lots of systems now, especially EMS systems, prefer IO. So that's going to cause a bit of heartache for some people, I think, in terms of writing guidelines and how you nuance that so current practice isn't impacted. And Kate's works as part of a group looking at point of care ultrasound. Did you want to talk about that, Kate?
Sure. So I think sort of similar to use of IO devices, point of care ultrasound has really taken off in popularity during lots of resuscitation, but including during cardiac arrest. And there have been observational studies suggesting that maybe, things like cardiac standstill after a certain number of minutes of CPR is useful for prognostication of return of spontaneous circulation. But I think when you really look systematically at the literature, as was done by the task force, the data is really not there to sort of hang your hat on that for prognostication. And I think, so again, the strict weighing of the evidence goes a little bit against what people think is true in practice. And so I think that would be, again, a challenge to translate into guidelines, and maybe somewhat controversial.
And do you consider that, Dr. Berg, that's one of the new added treatment recommendations?
We had looked previously in 2015 at use of ultrasound during cardiac arrest for improvement of outcomes, and really there was no data, and I think still there's essentially no data on that question, so that recommendation has not changed. So this is a newer one for using ultrasound findings for prognostication.
Do you sense that the literature has allowed you to revoke or completely alter the direction of previous recommendations, or the current literature has allowed you to continue to support aspects of your previous recommendations?
So my own take is that in most cases, for example, the oxygenation and ventilation after return of spontaneous circulation, the recommendations are similar, but the evidence behind them is stronger.
If we're picking out a new topic, we've covered the role of prophylactic antibiotics in comatose survivors of cardiac arrest, and the only RCT points towards, it's a French study, quite large numbers, points towards prophylactic antibiotics in ventilated survivors decreases incidence of pneumonia, but doesn't change overall survival and outcome. And some people would take that as, well, antibiotics are for the pneumonia, so they're good. And others would take that as, well, they don't make a difference on the critical outcomes of survival and neurological outcome, and so wouldn't use it. And microbiologists are very keen we don't give everybody antibiotics. So the ILCOR treatment recommendation doesn't recommend routine use, but leaves the door open to guideline writers to say, treat pneumonia. So again, that's a difficult area. One of the big topics we've covered, and again, there's a whole new raft of observational studies of neuroprognostication in comatose survivors, and clearly the worry is that we withdraw treatment on comatose patients too early when they're destined to wake up and have a good neurological recovery. And we've looked at all the studies published since the last detailed review of this in 2013, 2014. And again, the data still points towards there not being a single reliable test with sufficient specificity and sensitivity that one can use. And so the consensus on science points towards waiting a long time, avoiding confounders such as sedation, and using more than one test to avoid early and mistaken withdrawal of life support in comatose patients with cardiac arrest. And again, national councils will have to take that huge volume of data and the treatment recommendations and produce guidelines that work at the bedside.
And can you give us a sense of how many of these consensus on science are really for the advanced life support? I would say the early phase of resuscitation versus the later phase of resuscitation, or for the EMS teams versus potentially recommendation versus the in-hospital teams?
Most of the advanced life support treatment recommendations cover both out and in-hospital cardiac arrest. And the main difference when you look at the science is the timing of the intervention from the cardiac arrest. So ALS interventions in hospital tend to occur much earlier than out of hospital, yet most of the RCTs have been done out of hospital, and that's been one of the challenges for the ALS task force, in that we have a lot of out of hospital data for interventions that are done relatively late when the chances of survival are poor, and mainly observational data for in-hospital cardiac arrest and very few RCTs. So if you look at most of our treatment recommendations, they are nuanced for both settings and mainly extrapolate from out of hospital cardiac arrest. So interventions such as the use of epinephrine, airway interventions, and circulatory support, mechanical CPR, most of our knowledge on that science comes from out of hospital studies, and most of those studies show the interventions are more likely to be effective when given earlier. But there's no studies of early use in hospital, only observational data. So we've not talked about it so far in that we covered it a few years ago. So vasopressors, epinephrine, the paramedic study, which was an RCT, gave it about 20, 21 minutes post cardiac arrest and showed an improvement in early outcomes and uncertainty over long-term outcomes, yet in-hospital data from RCTs doesn't exist, and ILCOR has still given a recommendation that's supportive of epinephrine, yet that remains controversial. And Kate may have a bit more to say on that, and that's probably the most controversial topic we've published on in the last 2 years from the task force, the use of vasopressors.
Mm-hmm. Yeah, I think that's probably true, and it's certainly gotten a lot of attention in blogs and Twitter and all sorts of things. But I think the task force, as Jazz said, has sort of come down on it seeming like an intervention that works when given early, and in the trials generally is not given early. So I think based on observational data and in-hospital cardiac arrest, seems like it does make a big difference when given early on in arrest. And so I think the focus, what we've said in the treatment recommendation and sort of justification and other considerations is that we should be paying attention to trying to give these interventions sooner when they have a chance to have a bigger benefit. And then to your question about, do we look at kind of all stages of the cardiac arrest? I think we do. Certainly the recommendations for, intra-arrest, immediate post-arrest management and more ICU level post-resuscitation care and prognostication. I think the only, there are some intra-arrest interventions that are thoroughly covered by the BLS task force. So that, some of those are in that section rather than in the ALS. But otherwise, I think it covers the whole spectrum.
I think it's important to Anne-Marie that ILCOR writes these CoSTRs for the global resuscitation scene, and in some countries, many in-hospital interventions are done pre-hospital. So we know, for example, the French EMS systems, in some of them they do pre-hospital ECPR, lots in other settings, patients get taken into hospital for similar interventions. So the guidelines in terms of the CoSTRs we're writing tend to be fairly generic, and it can be applied to wherever critical care type advanced life support interventions can be done, and depending on the EMS system or the hospital system, they can be done across a range of settings.
And if you've probably noticed and were able to understand the key gaps for some of the most important topics, what would you say are maybe the top 3 or more or less, depending on, are the most crying needs for actual data to be able to provide recommendations on practices that people either are doing and there's no evidence for, or on practices that people would like to push forward and there's still no proper evidence to support?
As a medical intensivist, I treat a lot of in-hospital cardiac arrest, so I would like to see a lot more data there. So from everything from targeted temperature management to medications. And, I think a French trial from just last year was the first trial of pooling ever to include any in-hospital patients, but sort of mixed together with out of hospital. So I think those are the topics that come to my mind.
Yes, I think that's important because when you look at actual numbers, the numbers of in-hospital cardiac arrests are similar or similar to the number of out-of-hospital cardiac arrests. Yet, I think there's very few studies in terms of RCTs of in-hospital cardiac arrests, and the challenge is I think it's much more difficult to do an RCT when you've got hundreds of small hospitals compared to one EMS that may cover a large population. So in terms of setting up a trial, you'd have multiple sites. And that's one of the challenges, I think, for people to run big in-hospital RCTs. And then once those happen, the issues remain the same: use of vasopressors, use of, which is the best airway intervention, the role of monitoring and titrating care. So I think one of the challenges for ALS is that it covers everything from, using an AED onwards in terms of complexity. And we're trying to meet everybody's needs. So there's lots of things people are writing about in the literature in terms of taking people to the cath lab with ongoing CPR, use of ECMO, lots of device technologies, high performance CPR, which there isn't much in the way of data on, but there's a lot of anecdotal evidence or quality improvement that, our system did this and we get lots more survivors, and how you turn that into a ILC or CoSTR, I think is very challenging.
One of the questions about potentially adults are not all the same. Do you think the 2020 statement or CoSTR statement addresses the young adult, the older adult, adults with different types of conditions, pregnant adults, and will provide information for these different jurisdictions to try to have guidelines for those different types of adults? Or are adults all the same?
I would agree that adults are not all the same. I think and this might be another thing that makes in-hospital cardiac arrest research really hard to do, is that I think etiology of arrest and what's going on at the time somebody has an arrest is, I think, so important in somebody's outcome. And so, in some ways, again, especially in the in-hospital side, when we're dealing with fewer true, myocardial infarction related arrests and lots of other causes, whether you're really studying one disease process or the sort of end outcome of a lot of different disease processes, I think is unclear and makes it very hard to study cardiac arrest as one disease. So I think, somebody who has a cardiac arrest from an opioid overdose could have a very different prognosis and outcome than somebody who had a similar downtime, but because of a STEMI. So to me, etiology might be even more important than age, but clearly something important to get better at in the way we do trials.
Yeah, I agree. And I think we have produced some evidence update information in our CoSTR specifically for pregnancy, pulmonary embolism. Yeah, the evidence updates show very little in the way of changes to the consensus on science and treatment recommendation, in that for many of these issues, we're really relying on observational data. And so it's very hard, it's more based on values and preferences, what the guidelines will be rather than hard data.
And and last question, what are your task force members currently working on and should people look for in the next cycle?
There's two ongoing topics that we've started or in process, and one of them is post-ROSC coronary angiography and percutaneous intervention. And I think everybody agrees that if someone survives a cardiac arrest and has an ST elevation myocardial infarction, they should go to the cath lab, and if there's a culprit lesion, there should be primary percutaneous intervention, coronary intervention. The group where there's more uncertainty, and I think there's several RCTs going on, is a group that has a primary cardiac arrest, but does not have clear ST elevation on the initial ECG. And I think it's a big interest for, whether that group should go to the cath lab early or wait. And by early, within an hour or so of presentation in hospital, or wait till the next, planned angio list. And at the moment, there's centres where they do it early and centres that wait. And I'm sure lots of cardiologists are looking eagerly on what ILCOR has to say and what all the RCTs, will find, because it will make the difference of whether you get called at 3 a.m. or not. And then the other topic that we're going to start looking at is targeted temperature management, which is a hot topic, literally, in terms of there's uncertainty over what temperature is best. And the TTM trial published in 2013 showed 33 and 36 were equivalent. Unfortunately, the data shows that the trial probably led to people abandoning TTM altogether. So there's data from Australia and other centres where, and the UK data shows the same, where people took 36 to mean normothermia, and maybe that was associated with worsened outcomes. And the TTM2 trials going on at the moment that's comparing 33 with 37 and controlling fever or keeping the temperature below 37.9, and that should report shortly. And as soon as that's out, we'll be updating our current CoSTR on TTM, which sort of sat on the fence a bit and said, choose any temperature between 33 and 36 for 24 hours and rewarm slowly. And so that's meant the people who like 33 were happy and the people who like 36 were happy. But I think that story is going to run.
Well, lots to look forward. Thank you, both of you, for taking the time to talk to us about the 2020 ALS Consensus on Signs that ILCOR will be deploying this fall.